Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And our topic tonight is colorectal cancer. And our guest is Dr. Shankar Raman, a good friend and colleague of mine. Welcome, Dr. Raman.
Thank you so much for having me, Dick. It's a pleasure.
And Dr. Raman is the director of the MercyOne Colorectal Cancer Surgery Division. And he is also, he's got a lot of other titles, including like Chief Medical Officer for the Central Division of MercyOne. But that's not exactly right. But anyway, he's an important person. And he's also a good friend of mine. So thank you for being here. And we're going to get to know you as a person first, and then we're going to spend the hour talking about colorectal cancer. But first, tell us about yourself. Where are you from, Shankar? Where did you grow up?
Yeah, I grew up in South India, a town called Pondicherry, which was ruled by the French when the majority of the rest of India was ruled by the British. Interestingly, it is a coastal town on the Bay of Bengal. But I didn't know how to swim until about last year when I took classes at the Y.
Right.
Right.
And so what about French? Do you speak French?
I speak very little French,
Okay.
tiny portion of French. The town still has a lot of French flavor, French culture, and the streets are in French. And there are French citizens living in India who have the same genetic makeup as me, but they are French citizens.
Okay. And is the community you grew up in, is it a large city, millions of people, hundreds of thousands of people?
So I would say the size is similar to Des Moines, which was one of the reasons, I came to Des Moines because, geographically the size was similar, but the population is much denser. So we have way more people. I would say probably it's about 1.2 million is what the population is for the same size as Des Moines.
And tell us a bit about your educational experience. I know you have girls that are going to public schools in Des Moines. How does the education system, grade school, high school, college, how does that compare in India to the United States? And maybe tell us about your educational journey.
Yeah. So I studied in a boys' school that was run by Catholic missionaries. So that's where I studied because it was thought that it was the best school because it was a place where discipline was strongly enforced.
Did you ever get your knuckles hit with a ruler by a nun?
By a pastor, by father. Yeah, I did
Oh,
have
okay.
a
Okay.
lot of those things. And once, when I was running around with my friend, I accidentally bumped into him. He was coming down a flight of stairs, and then I got slapped on my face pretty hard that my ear was ringing for a couple of days.
Oh, wow. Okay.
Yeah,
Okay.
yeah, I think that was probably in early middle school. I think maybe seventh grade.
Okay.
That's where I studied. Indian government schools, the education was not. I would say the focus on education is good, but it's not as great as it is in some of the private schools that are run by either, historically they have been run by missionaries or more there are private entities doing, in that sphere. So I didn't go to a government school, but I had friends who came from government school, and it made me realize that it's not the school, but it's more the candidate who makes a difference.
And then what about like college and medical school? How does that work in India?
So after high school, you enter into either a medical school or any of the professional schools. There is no 4-year college like it is here in the United States. This follows similar pattern in the UK as well, or in Commonwealth countries, where after high school, typically you go to medical school or engineering or whatever professional school that you aspire to go to. So entrance into medical school depends on your performance in high school exams as well as an entrance exam for the medical school itself, and it's super competitive. With a country of more than 1 billion, you have so many folks writing these exams, and as you score higher in these exams, you get the ability to choose the medical school that you want to go into.
And was the medical school that you went to near the
Right.
town you grew up? Okay.
Right. It wasn't the same town, and unluckily, it was one of the places where the central government, or the federal government, similar analogy to use here, had established schools in different parts of India, and there were probably about 5 to 7 schools, and one of the schools was in the same town that I had grown up.
Okay.
And I was able to get admission into that school because of the performance in the entrance exams, and it was extremely fortuitous that that worked out, because I didn't have to go and live in another town. And the Indian culture is such that you stay and live with your parents for as long as you can. It's not like,
Mhm.
a rite of passage where you leave the house at 18 so that you can shape your own path. So I was lucky that I stayed with my parents until I finished medical school and subsequently residency in the same place, and I got well fed throughout my educational journey there.
Yes. So, it seems like the pressure is on for high school students to figure out much earlier in life
Right.
what you wanna be when you grow up, 'cause
Right.
you don't have those 4 years of college where
Right.
many, many people change their minds about what they wanna do
Right.
from entering college to so then, at what point in your career did you decide you wanted to be a surgeon? And
Right.
then at what point did you decide you wanted to be a colorectal surgeon?
Right. So I struggled in medical school the first couple of years. They were not easy because I was 17 when I went into medical school, and I had no clue what medical school entailed or how much effort it took to do really well in medical school. And competing against all these smart minds from all over India was just a different level of expectation and performance and comparison for me. So I'll be honest and say that the first couple of years I struggled. And as I got more mature, I understood that it took a lot of effort to do well in medical school and to become a good physician and to become someone who can take care of people in a way that is dependable. So I had to really improve my performance starting in year 3. And it was around year 4. So medical school in India is about 5.5 years. So it's not 4 years like it is here. So 5.5 years includes 1 year of compulsory rotating internship. You are an intern in various specialties. It was around the end of year 4, beginning of year 5 is when I thought I would want to be a surgeon, because I enjoyed the surgical rotations. I enjoyed the hands-on experience, and I thought it was cool. There were also great mentors in the field of surgery for me, that I thought I could identify better with them than with other specialities, and that's when I chose to go into surgery.
Okay.
Colorectal
And
surgery was slightly later, having spent a couple of years in England, seeing some colorectal surgeons do some really great work, seeing the dissection, the planes. I thought that this is a field where I would have a lot of fun doing the operations that the specialty offered.
so your general surgery, residency was in India, but you did some rotations in London?
Right. 3 years of general surgery residency. That's the length of the residency program. So I got board certified in India. Then I practiced for about a year, year and a half, where I did other rotations as well, including pediatric surgery, where I worked as a senior resident, operating on young kids. And it was really cool to see young kids go through a very difficult operation and come out on the other side as if nothing had happened. And just, their resiliency was so impressive. I spent nearly 2 years in England, working as a senior house officer and as a registrar. The comparative levels here in the US would be a senior resident or a chief resident. And that's when I got the opportunity to work with colorectal surgeons and got to see really complex colorectal work, including rectal cancer work that really stimulated my interest to go into the field of colorectal surgery.
And then, colorectal surgery is a fellowship after general surgery residency. So where
Right.
did you do your fellowship?
My fellowship was at Henry Ford in Detroit. Yeah.
And
So
and
after London, I was in New York for 5 years, completing a general surgery residency again. That was my third general surgery training, India, England, and here. And then after that, it was a 1 year of colorectal fellowship at Henry Ford in Detroit. And I liked the Midwest so much. The Midwestern values, the people, the culture was just something that resonated with me so much that we wanted to be in the Midwest, and that's how we found Des Moines.
right. And your wife is also a physician.
Right. She is a pediatrician.
Yes. So, you lead the colorectal cancer program here at MercyOne. So, let's talk about colorectal cancer. As I mentioned at the outset, March happens to be Colorectal Cancer Awareness Month. Why does colorectal cancer deserve a awareness month?
um, because I would like to think that because it's the area that where I work in, but in reality, it's because colorectal cancer, when diagnosed early, is treatable, is preventable, and is curable for most stages. So it makes a huge difference because it is the third most common cancer here in the United States, and is also one of the cancers that has a high mortality rate after lung cancer. So and we have good screening methods that are available to detect colorectal cancer and to treat it, especially with colonoscopy. We can find polyps and remove them before they turn into cancer. So there is a huge public health opportunity, public health benefit. And that's why there is a colorectal cancer awareness month, because increasing the awareness is a first step in making sure that we can address this public health problem.
Right. So it's one of our more common cancers. It's also one of the cancers that causes death, but as you pointed out, is also a cancer for which we have screening.
Right.
Um, Before we get and I'd like to talk about all of those: prevention of colorectal cancer, screening, early detection, and then treatment. But before we do that, maybe clarify the difference between colon and rectum. What's similar, but why do we have two different, why do we call it colorectal, and what is the distinction between colon cancer and rectal cancer?
Right, right. Thanks for asking that. Um, the colon is the word for large intestine, which is the last, I would say, approximately 5 feet of the intestinal tract. The end is the rectum. The rectum is the last 6 inches of the large intestine, and the colon is the rest of it. So nearly 4 and 3/4 of feet is the colon, and the last 6 inches is rectum. The colon goes from the right side to the upper abdomen to the left side, and then goes down to the pelvis where it joins the rectum. And the reason why it is separated into colon and rectum is that the cancer in the colon is differently treated than a cancer in the rectum. And the rectum is located in a tight area within the confines of the bony pelvis. And therefore, there is a lot more opportunity for the cancer in the rectum to spread, either to adjacent structures or to lymph nodes. And the way we treat it is different as compared to the colon. That's why making this differentiation and being accurate about it is crucial.
Yeah. And that's a very good point. And sometimes um, patients might say just generically they had colon cancer, and when you get into the details, you find you have rectal cancer. And for some reason, saying colon seems more polite than saying rectum, and saying rectum always seems more polite than saying anus. But
Right.
they're just different parts of the body. And even though we call you a colorectal surgeon, the anal canal and the anus also fall into your specialty.
Right, right. Yeah. We are the proctologists who used to do, proctology was a previous specialty that then subsequently morphed into colon and rectal surgery, the American Board of Colon and Rectal Surgery. Yeah, we do take care of entire spectrum of colon, rectum, and anus, all the disorders of these areas.
hmm And we're going to focus on colorectal cancer. But before we do that, you also take care of benign conditions of
Correct.
the lower digestive system. What are some of the benign conditions that colorectal surgeons would also take care of?
The most frequent benign condition that we take care of is diverticular disease. Complications from diverticular disease, including diverticulitis, that can present with abscesses, that can present with perforation, that can present with narrowing of the colon, causing an obstruction or a blockage. That is the number one most benign condition that we take care of. In addition to that, we also take care of volvulus, which is a word for where the intestine twists. The sigmoid colon is a very common area where the volvulus can happen. We also take care of prolapse, where the rectum falls out and it needs to be brought back in and sutured. This can happen especially in women who have had multiple pregnancies. They might have vaginal prolapse or uterine prolapse, where the structures in the pelvis are not adequately supported, and they lose their support. So things become lax, so the organs fall out, including the rectum, so it needs to be brought back in and fixed in place. In addition to that, other benign conditions that we take care of pertain to the anus. This includes hemorrhoids, abscesses, fistula, pilonidal disease, and whatnot.
Great. Great. So now let's focus on our main topic of this evening, and that's colorectal cancer. So you gave us a kind of an anatomic overview. Let's talk about what can we do to prevent colorectal cancer, and then we're going to talk about screening and early detection. So what are things that individuals can do to help reduce the risk of getting colorectal cancer?
Um, Colorectal cancer, for the most part, has modifiable risk factors. We cannot control the genetic package that we are born with, so that becomes something that we just have to accept. But understanding those genetic factors, but also having an understanding about the modifiable risk factors is crucial. The modifiable risk factors include diet, what we eat. The colon doesn't like red meat. The colon doesn't like processed food or processed meat. What the colon likes is diet rich in high fiber, fruits and vegetables. The colon really loves those. So modifying the diet is an important element. Studies also show that obesity is a risk factor for colorectal cancer. So adjusting the diet is and handling obesity and modifying obesity to as much as possible is also helpful. Alcohol is considered to be a risk factor for colorectal cancer. So avoiding alcohol, as you know, Dick, there is no safe amount of alcohol anymore. Previously, it used to be considered that we could have, two drinks if you're a male or one drink if you're a woman. But that's not true anymore. There is no safe limit of alcohol anymore at all. Smoking is another risk factor. Smoking just doesn't cause, or it's not associated just with esophagus or lung, but it's also associated with colon cancer as well. I think in addition to this, one of the other major risk factor is lack of physical activity. Sedentary lifestyle is associated with increased risk of colon rectal cancers. So having a very active lifestyle is crucial in mitigating the risk of colorectal cancer.
One other risk factor that we're beginning to learn more about, and I was just part of a conference today, is environmental
Right,
exposure to certain chemicals.
right,
And, it took decades to figure out that smoking a cigarette caused lung cancer. We're now in a phase where we're all in the modern industry. I mean, I look around this room, the plastics, the food additives, the
right,
food dyes, but also the insecticides, pesticides, herbicides, fungicides, fertilizers. We're learning more and more about those
right,
chemicals and their association with cancer. And so that's another modifiable risk factor that we're learning more about. But
right,
until we learn exactly what's causing, it's hard to modify those risk factors. But
right,
one thing that we're beginning to talk about, I'm not necessarily recommending it to everybody, but should we be thinking about filtering our water, because all of these chemicals eventually get their way into our water stream
right,
and into our.
right.
So those are ways of preventing cancer and colorectal cancer. Now let's talk about screening. Colorectal cancer is one of the 5 cancers that right now we have validated screening mechanisms. So talk about the principle of screening cancer, and then tell us what are the different ways in which one can can screen for cancer in individuals that don't have any symptoms of colorectal cancer?
Right. So, yeah, screening is the technique that we use in the medical field to talk about identifying a condition or identifying a disease much early on, that gives us a lot of time to take care of the problem before it becomes severe or before it becomes life threatening. Specifically for colorectal cancer, there are different ways of doing screening. Essentially, the idea of screening is to identify lesions or growths that happen within the colon and take care of them in a timely manner before they become ominous or before they become dangerous. Ideally, we would want to identify polyps, which are little growths, which are like skin tags that grow inside the colon. And if they are not removed, they will continue to grow and they will become cancerous. This has been studied well. This is called as the adenoma carcinoma sequence within the colorectal pathology. So, identifying an adenoma, which is a word for a precancerous colon polyp, and removing that polyp is crucial. The best way to identify a polyp would be to do a colonoscopy, which pretty much everyone knows. Um, there are other ways of identifying colorectal cancer, because when the cancer develops, it starts leaking blood within the colon, and that blood gets eliminated in the stool. So you can test the stool for blood. In addition, the cancer also sheds DNA, which is the nuclear content from the cancer cell, and that also gets shed in the stool, and the stool can be tested for that. There are ways of testing for the blood, which can be stool guaiactas, which was the older technique, or there is a fecal immunochemical test, which is called as a FIT test, which is much more sensitive to picking up the stool that contains blood. The stool DNA test is also well established. Cologuard is a stool DNA test, which is commonly used, and that needs to be done every 3 years if the Cologuard test is negative. So you have stool-based tests that can test for colorectal cancer, and then you have others that include putting a scope like a colonoscopy and looking inside the colon. And for those who don't want to undergo a colonoscopy, there are some other techniques, but they are not on the top of my list, nor I would recommend. These include like CT colonography or barium enema, which are much more intensive in kind of prep, and you need to have special radiology and special techniques to do those procedures.
And Dr. Raman, maybe let's talk a little bit about a brand new screening test called Shield,
Right.
and it's a blood test. So maybe share a little bit about the blood test as a screening for colon cancer.
Right. So this is absolutely heart of the press stuff that's just come out. This is a blood test that is used for detecting cancer cells that are in the blood. The understanding is that even if they are non-cancerous cells, the DNA from those cells are found in the bloodstream. And by identifying those DNA within the blood test, we can identify colon cancer. The question is, what happens once you find it? What is the next best step? When should you find it? Or when should you do the next step, which in my mind is a colonoscopy? So you could consider using the Shield test, but we need more extensive studies showing that this is truly beneficial and this truly saves patients' lives.
Yeah. And so with either the blood test or the stool test, if they're positive, then it's essential you go to the next step, which is colonoscopy.
Correct.
Yep.
Correct.
And one thing, the colonoscopy, as you've already pointed out, but I kind of want to highlight it, colonoscopy is a screening test, but it is also something that can help prevent cancers. As you pointed out, a colonoscopy, when you're in there, even if you don't see a cancer, you remove polyps, and by removing those polyps, you may actually prevent a patient from getting cancer.
Correct. Correct. Yeah, the colonoscopy is a great test. Yes, the challenges with doing the prep, which most patients don't like. But the prep has improved so much over the past few years that it's become very palatable. Curiously enough, I'm undergoing my colonoscopy in 2 days. March is Colorectal Cancer Awareness Month, and I thought no better time than to get my scope in 2 days' time.
Could we film that live and do it?
Absolutely.
Are you going to have anesthesia, or will you do it without anesthesia?
I'm going to have some sedation, but not. I'm not going to be fully under. And my goal is to watch the procedure as much as I can,
Okay.
so that I have a much more grounded perspective of what my patients go through when they undergo colonoscopy.
Can we interview you during the procedure?
I'm up for that, Dick. You know
Okay.
me. I'm always up
I think
for
the
up for
last
those
person
things.
that did that was Katie Couric. So you could be the Katie Couric of Iowa. So we'll talk more about that. So let's talk now about someone who has been identified as having cancer in the colon,
Right.
and then we'll go through the same scenario with someone who has cancer in the rectum. So let's start with colon, and as you already told us, that's about the first 4.5 feet of the large intestine,
Right.
and it's kind of up in the abdomen as opposed to down in the pelvis.
Right.
So you've just done a colonoscopy and identified cancer in the colon. Let's talk about treatment. How would one treat colon cancer?
Right. So once the diagnosis of colon cancer is made, when we do a colonoscopy, we take some samples and send it for testing. And when the test results come back confirming that this is colon cancer, the next step is to accurately stage what stage the cancer is. The way we do it is by doing a CT scan of the chest, abdomen, and the pelvis. And we want to see if there are any spots in the liver that are suspicious for cancer, if there are any spots in the lung that are suspicious for cancer, or anything else that might, change the treatment plan or affect what we need to do. Assuming that there is no widespread tumor, which would make it stage four, there is nothing in the liver, nothing in the lungs. There are probably some lymph nodes right next to the cancer. Then the next step would be to proceed to surgery. We also do a blood test called CEA, which stands for carcinoembryonic antigen, which is a marker for colon cancer. We check the blood test and then we track that number sequentially as the patient goes through treatment. So that is done before. As part of our multidisciplinary cancer conference, we also discuss with all the experts who touch these patients with cancer. These include our medical oncologists, radiation oncologists, radiologists, pathologists, and surgeons. We look at each patient's case and we come up with the best individualized treatment approach for each of these patients. Why do we need to discuss? Because we know that discussing these patients and having multiple eyes look at the patient issue, patient scans, patient reports helps produce better decisions, so that it's not just one person making a decision that could be suboptimal in certain situations. So having a varied perspective helps the best decision to come up. So for stages one, two, or three, typically it is surgery, which can be done through small incisions using a robot. And then we wait for the final report after removing the cancer. When we do the operation, we remove about 6 to 8 inches of the colon along with the lymph nodes, and then we send it for testing. Once the test results come back, if the lymph nodes have cancer, then it becomes stage three. Typically, chemotherapy is recommended for these patients.
Right. So as you pointed out, surgery is generally first for colon cancer,
Correct.
and then depending on the results of the surgery, chemotherapy is sometimes then done after they've recovered from the surgery.
Correct.
As you're describing tumor board, it reminds me, or our multi-cancer, multidisciplinary cancer conferences, that there's one risk factor we kind of alluded to, but I'd like to talk about a little bit more, and that's genetic.
Right.
Some individuals have inherited genes from mom or dad that make them more likely to have colorectal cancer. This would be a good time to talk about those genes and talk about Lynch syndrome and how, if you do have it, that could alter the treatment.
Right. Right. Yeah. So about 5% of colon cancers have some genetic mutation. And less than, probably around 1 to 2% of those are associated with these syndromes, Lynch syndrome or FAP, which stands for familial adenomatous polyposis, which go from one generation to the other. And therefore, we have a pretty good understanding of what these entail and how they should be treated. So all colon cancers are tested for genetic mutation. That's standard of care now. It wasn't the standard of care 10 years ago. We used to test individually, depending on the family history. But now the recommendation is that all of these cancers should be tested for genetic mutation. And if there is a genetic mutation within the cancer that points to a possibly mutation that goes from one generation to the other, then we have the patient meet with the genetic counselor and undergo genetic testing. If we find genetic testing results showing that there are mutations, then we call them either as Lynch syndrome or one of the variants of Lynch syndrome, or whatever that might be. Why is that important? Patients with Lynch syndrome are known to have a high risk of developing colon cancer throughout their lifetime. So if a patient with Lynch syndrome has cancer on the right side, if we remove only the right colon, then the rest of the colon has a much higher risk of developing cancer over their lifetime as compared to someone without Lynch syndrome. And therefore, having this information before we do the operation is important, because at that time, we can remove probably about 80% of the colon and hook the ball back together and thereby decrease the risk of developing cancer later on. That's why the genetic testing results are crucial before we go into surgery.
Right. And then also, the additional testing then would be offered to the relatives of
Right,
the,
right,
especially the children, but also the siblings of
correct,
those individuals
right,
that have the syndrome. So we've talked about the treatment of colon cancer, and just to highlight what you told us for colon cancer, and that's part of the large bowel that's in the abdomen. For stages 1, 2, and 3, generally surgery is first, and
correct,
then if there are positive lymph nodes, then chemotherapy would follow. Now
correct,
let's talk about a different patient, and this patient has had a colonoscopy, and let's say this patient presented with some blood on the toilet paper, and that led to them getting a colonoscopy, and you found a tumor in the rectum. um, how would the staging workup be different, and how would the treatment algorithm proceed with someone who has a rectal cancer, which is the large bowel down in the pelvis?
right, right. So once patients get diagnosed with rectal cancer, there are some crucial things that we want to know. One is how far from the anal opening the cancer is. This makes a difference as we come to surgical treatment. So we want to measure how far it is from the anal verge. So we do that either by putting a scope that has measurements or by doing a finger exam. We can get an idea of how far from the bottom the cancer is. The workup for rectal cancer is also very similar with some marked differences. We do the same CT scan like we do for colon cancers. We do a CT scan of the chest, abdomen, and pelvis. We get a CEA level. In addition, for rectal cancer, we do a pelvic MRI. An MRI is magnetic resonance imaging scan that gives us a lot of intricate details on how thick the tumor is, how much of the rectal wall is involved by the cancer, and if there are lymph nodes outside of the rectum that help us determine what the next best step is. So if the cancer is going through the wall of the rectum, and or if there are lymph nodes, then we want to shrink the cancer down with chemotherapy and chemoradiation before we do surgery. Why? If the tumor has gone through the wall, or if there are lymph nodes, doing surgery is associated with a higher risk of the tumor coming back than if we had treated them with chemotherapy and radiation first.
Right. So the big distinction is colon cancer surgery first, followed by chemo if necessary. With rectal cancer, that is a bit advanced, maybe stage 2 or 3, we might start with the chemotherapy or chemotherapy and radiation
Right,
and do the surgery
right,
later.
right.
Yeah. One of the things that we are seeing, so we made great strides in improving cancer treatment, but we also know that every form of cancer treatment, chemotherapy, surgery, radiation therapy, even immunotherapy, each of those has side effects. And there was a period of time where we just kept adding more, and we did more treatment, more treatment, more treatment. Over the last 10 years, I've seen that we're now trying to say, when can we back off
Hmm.
some forms of treatment?
Right.
There was a time where we thought everybody with advanced rectal cancer had to have surgery and chemo and radiation, and now we're trying to determine, can patients still be cured with fewer of the treatments to end up with fewer long-term side effects? Maybe
Right.
talk a little bit about where we are in
Right.
that phase of deciding which treatments are necessary and which ones might be able to be avoided.
Right. Yeah. This is one of the exciting time in rectal cancer. In the field of rectal cancer, because the advancements are coming at this pretty fast. Over the last couple of years, there have been at least a few studies that have shown that we don't need to treat every patient with this combination of surgery, chemo, and radiation. There are some patients who need only surgery. There are some patients who need chemo plus surgery, and there are some patients who need all three. Identifying and taking care of those is really crucial, which is why we want to do the appropriate staging with CT scan and MRI. Once those are done, if the tumor is early stage, meaning it is just limited to the wall, there are no lymph nodes, then surgery is the next best option. Once surgery is done, then we know whether the lymph nodes have cancer in them or not based on the final pathology. If the lymph nodes don't have cancer, it's done. Treatment is done. No further need for chemo or radiation, just observation is sufficient. And then there are patients who come with advanced cancers, and they are bulky enough and they are located high enough, but they are not bulky enough to invade other structures, which might be the prostate in male, or the vagina in female, or the bladder, or ovaries, or whatever. When there is no invasion of these organs and they're located higher up, we can give chemotherapy and see how they respond. If they respond well, then we can go straight to surgery without having to put them through radiation. The idea of limiting the treatment is because of the side effects associated with each of these. Surgery, chemo, or radiation, they're all really good when it comes to curing the cancer, but they can all leave the patient with side effects as they're going through treatment. So we want to optimize the right treatment with minimizing the side effects so that patients can have both cure and quality of life.
Yep. And when we started talking about the rectal cancer, you made a point that one of the important pieces of information to know is how far above the anus is the cancer. Obviously, obvious to you and I, and maybe not to everybody, but if a cancer is really low down, very near the anus, it's very hard, and if not impossible, to remove part of the rectum and reconnect the
Right,
rectum to the anus and
right,
still have good bowel control. So
right,
let me have you talk about the difference between what we call a low anterior resection
right,
and an abdominal perineal resection. And
right,
that's basically who needs to have a colostomy,
right,
and under what circumstances can you do rectal surgery and not have a colostomy? When do you need a colostomy? When do you need maybe a temporary colostomy
right, right.
versus a permanent colostomy?
Right. Yeah. So the way I would explain this is that, think of the rectum as a storage organ that stores stool, and that helps us keep the stool until we are in a socially acceptable situation where we have access to the bathroom, so we can go and empty the rectum, evacuate the stool. The rectum has the storage capacity. The colon does not. That is a crucial element in understanding this. So let's say that the tumor is in the lower one third of the rectum, then the entire rectum pretty much needs to go. If it is in the upper one third of the rectum, we can remove that section and then save the bottom half of the rectum and have some storage capacity. Whereas if the tumor is lower down, all of the rectum needs to go. So if the rectum is gone, but there is only a very small amount of the anus is left behind and patient do not have good control, then it's hard to put the colon and hook it down to the anus and expect good function, because the colon does not have any storage capacity. Patients have to have 6 to 8 bowel movements a day. All of those are small bowel movements, terrible quality of life. In those situations, it might be better to have a colostomy. Secondly, if the tumor involves the sphincter muscles, which provide control to the rectum, there is no point in having a rectum, but if the sphincter is gone, essentially they'll be leaking all the time. So those are the situations where patients will need a permanent colostomy. Does a permanent colostomy mean that their quality of life is going to be terrible? No. Patients who have a permanent colostomy can lead fulfilling lives, personal, social, professional lives, including intimacy. For those patients whose tumor is located higher up, where we can remove the rectum, put it back together, it's called as a low anterior resection. Those patients sometimes might need a temporary colostomy so that the stool can be diverted from this plumbing. Imagine, an area of plumbing that has been done. We want to keep the water away from it. So we open up a side valve upstream so that the water goes through the side valve and doesn't go into that new plumbing that we have created. Those are the patients who need a temporary stoma. When do these patients need a temporary stoma or a temporary colostomy? When patients have received radiation, there is a higher risk of leak from that plumbing. So we try to divert the stool stream, away from that. Those are the patients, or in those patients whose health is not great, where we think that the plumbing may not heal well. Those are the situations where we want to do a temporary stoma.
Okay, great. Then in terms of follow-up, what are some of the important issues involved in following patients who have successfully undergone treatment, chemotherapy, radiation, surgery, whatever was necessary?
Right.
They're now cancer-free. How often do they need to be seen, and what sort of tests need to be done to do surveillance for the risk of recurrence?
Yeah. We talked about combination of chemo, radiation, and surgery for rectal cancer. Thankfully, again, within the last couple of years, a subset of patients, they don't need surgery. They do very well just with chemo and radiation. The cancer melts away. And these patients are on what is called as a watch and wait protocol, where we are watching the rectum very closely and we are waiting to see if the rectum starts behaving aberrantly or starts developing cancer. These patients are in a very intense surveillance. So they will need to have an exam in the office with a finger exam every couple of months. Scope exam, which is where we put a flexible scope, a camera into the rectum and look at the area of the cancer, make sure that nothing is going all right. And then we also do an MRI every 4 months. So these three are done every 3 to 4 months for the first couple of years, and then we stretch out the interval afterwards. For those patients who have undergone surgery for rectal cancer, now they are cured of cancer, we do a colonoscopy in 1 year time. We also do a CT scan at that time, and then go forward from there. In addition, they will be seen in the office every 3 months or so for the first 2 years, and then after that, every 6 months for the next 3 years.
Okay, great. We're going to open up to questions. So we're going to open up to questions. We've got a live studio audience, and we also have individuals that are watching us live streaming right now. If you're watching us live streaming, please put your questions in the comments section. So questions for Dr. Raman about anything to do with colorectal cancer, prevention, screening, treatment. We didn't even get into constipation and the best way to have good bowel movements, but he's the doctor. If you have any questions about poop, feel free to ask Dr. Raman.
Right. I am the poop doctor, as my nephew calls me.
There we go. So Poon, you're up first.
Can you remind us what age someone should start getting a colonoscopy?
The age, so it's 45 years is the age for screening for those with average risk. For those with a family history of colon or rectal cancer in a first degree relative, the age is 40 or 10 years younger than the age in which the family member was diagnosed. So, an example would be, let's say that somebody is diagnosed at the age of 45 with a colon cancer. Their children will need to start at 35 years of age for screening. Um, if someone was diagnosed at the age of, 50, then their children will start screening at the age of 40. And then there are others who have family history of colon polyps. Again, they would also start either at 40 or 45.
Okay. Next question, Tim.
Hello, doctor. I have hopefully a quick question. You touched upon it about the side effects, and one of the side effects is the storage of the spool of where that goes. Is there such thing as scarring or any type of side effects from the other two treatments of chemotherapy and radiation?
Right. Yeah. Radiation can cause a lot of scarring within the pelvis. Radiation can not just affect, radiation, though it's given for the rectal cancer, it can also affect the surrounding structures. And the pelvis is a very tight space. We call it as a hollow glass tube with the rectum in it and all the other critical structures. So that scarring can cause issues with urination, with sexual function, as well as with bowel function as well. And sometimes can irritate the rectum to the point where the rectum bleeds from the scarring caused by radiation.
Yeah, and I would just add to that, kind of to amplify what Dr. Raman said, radiation definitely can cause erectile dysfunction in men. So radiation for rectal cancer can cause erectile dysfunction. It can also cause vaginal dryness and sexual dysfunction in women. Also, if it's a young woman who hasn't gone through menopause yet, radiation to the pelvis can definitely affect the function of the ovaries and may cause early menopause. And then the chemotherapy can, in women, cause early menopause. Also, one of the lingering side effects for individuals going through the type of chemotherapy that we use for colorectal cancer, lots of peripheral neuropathy, numbness of the hands and feet, that can be a lingering forever side effect of chemotherapy. So just some of the other side effects.
Right.
And one of the reasons why, when appropriate, we're trying to back off treatment if we can successfully cure the cancer without having all of the forms of treatment. So those are some of the side effects. Other questions?
Yes, I have.
Angelina, yes.
I have two questions. One, what causes constipation? And the second one is, what causes hemorrhoids?
Okay, so those are somewhat related. What causes constipation is the lack of enough fiber in the diet, lack of enough water, lack of physical activity. We know that fiber is essential because fiber provides bulk to stool, and water helps the fiber, swell up, and there is more residue within the colon, and the colon can push that forward and get it out, through the rectum. Physical activity is also shown to be associated with constipation. So the more active you are, the more your gut starts moving. So that is also crucial. That being said, there are some patients in whom all these conditions are optimized and their gut just doesn't want to work. So these patients are constipated in spite of taking numerous supplements, laxatives, as well as fiber, water, and physical activity and whatnot. We think that these patients, the nervous system of these patients, how it goes to the intestines, that wiring is something off, and therefore the colon does not move the stool forward to generate, to produce a bowel movement. And there are medications to address those conditions. What causes hemorrhoids? Constipation is the number one cause for hemorrhoids. The longer someone sits on the toilet, the longer they strain, the more hemorrhoids swell up and they bleed more. So avoiding constipation is the first treatment for hemorrhoid treatment as well. So anytime I see someone with hemorrhoids, I tell them, you got to take enough fiber, you got to drink lots of water, and you cannot sit on the toilet for more than 5 minutes. now with smartphones, we all tend to do things while sitting on the toilet using our phone, and that's a strict no-no. So we can't sit on the toilet for longer because the hemorrhoids then would swell up because blood just goes to hemorrhoids due to gravity. There is no support to that region when we are sitting on the toilet. So then they swell up and they get, irritated and they bleed.
And absolutely, positively, do not take the Sunday New York Times into the bathroom.
Right.
Gary.
I'm just curious. Does colorectal cancer, does that seem to be prevalent more in females or males? Because I think of this as because I do have a cousin that she's had cancer, colorectal. I don't know if it's colon or rectal, but then I also have a sister that seems to have quite a few polyps that she has to have removed every time she has an examination.
Yeah, the rectum is known to be more in men for reasons that are not entirely clear. The colon, the distribution between men and women is pretty much the same. The number of, again, polyps finding, men tend to have slightly more polyps as compared to women. Smokers tend to have more polyps compared to non-smokers. But certainly for the rectum, it is known that men are more likely to get rectal cancer than women.
Okay. George, do we have any questions from our live stream? Okay. I have.
The question I have, I heard you talk several times about reattaching things in the interior. Now, exterior stitches on skin, I get that. But I've always wondered, how do you reattach things? Do you use stitches? What is that?
Yeah, we use a combination of staples and sutures. These are metallic staples that are super small. They're made of titanium, and they get and they bring the bowel together and they hold the bowel in place until the bowel can heal by itself all around, and then the staples are shed in the stool.
And another question, I've been told that in some societies, this is not very prevalent as it is in America, colorectal cancer,
right,
which points a finger at behaviors or society or something like that, diet and exercise particularly. But as Dr. Deming said at the beginning of the show, there's all kinds of factors that are possible, and they're much more prevalent in this country than they are in other parts of the world. Is
right.
all that true?
Right. I agree. I spent about 6 years in India and about a couple of years in England, all in surgery, before coming over here. I did not see a single patient with diverticulitis in India. That's because of the diet. It's not processed. It's high fiber, lots of fruits and vegetables, and the use of meat or consumption of meat was not as prevalent as it is in the Western society. Typically, Indians, even though meat eaters, they would not eat meat every day, and they would eat meat, once every few days or so, and certainly not something that would be in a freezer that they would consume 6 months or a year later. That just was never the case. Processed food, Dr. Deming talked about fertilizers, insecticides, fungicides, pesticides, and all that. They were all substantially low. So I think those are all the factors that are probably associated with less risk of colorectal cancer as compared to what we see here in the United States.
So, Dr. Raman, a couple questions. One, bacteria, healthy bacteria, probiotics. Are you obviously the natural way is you just eat lots of fruits and vegetables, and in the process you feed the healthy bacteria. So maybe talk a little bit about probiotics. And we can't end without me asking you about the squatty potty. And do you believe that there are some physiologic principles involved with the squatty potty that should cause us to maybe consider that as a tool to enhance defecation?
Right. Yeah. The squatting position is considered to be the more natural way for evacuating the rectum. So a squatty potty, yes, if if you want to consider it, go for it. You're not going to harm much. But it doesn't make sense to use a squatty potty and sit on the toilet for more than 5 minutes. Ultimately, you want to spend as little time on the toilet as possible. That doesn't mean that you're going to grunt and strain and cause problems or blow out, a blood vessel in your eye or wherever. You want to make sure that the stools are soft by taking enough fiber and by drinking enough water that you can evacuate it in less than 5 minutes. So there is no problem with using a squatty potty if someone wants to try it. To your question regarding probiotics and prebiotics and whatnot, I think there is a ton of data that is coming out, but we haven't really figured out these are the probiotics that we need. I personally am not a huge fan of consuming extra stuff. I would say whatever you can get in your diet, that's good enough, as long as your diet has a wide variety of fruits and veggies. In addition, I would say yogurt would be helpful for getting some of the benefits of fermented foods. And that has been associated with less intestinal inflammation, including celiac and Crohn's and whatnot. So yogurt, if you can consume yogurt, that's great. Whereas if you want to consume probiotics, go for it. They're not cheap. So just be mindful of that as you do it. And the data on that is constantly evolving for me to give one solid answer to that.
Great. Well, thank you, Dr. Raman. This has been exceptional. Do we have time for, we have one more question. Final question, Ron.
Just real quick, thanks for sharing all your information.
My pleasure.
As far as treatment goes, I know with other types of cancers, there's leaning towards new immunotherapies that are being developed.
Right.
Are they looking at anything like that with
Yes.
colorectal cancer?
Yes. Yeah. Well, thank you for asking that question. Like we talked about Lynch syndrome patients, there is a newer immunotherapy approach that is available. And studies on this show that these patients have complete resolution of the cancer. The point is this has been proven in rectal cancer. So study from the Memorial Sloan Kettering showed that these patients had complete resolution of the cancer, that they did not even undergo surgery, and they're just on observation and they're doing well. But like I said earlier, the percentage of patients who would be candidates for immunotherapy is really small. So that is important to know. And it is important to know the genetic mutation associated with the diagnosis to see if someone is a candidate for getting immunotherapy or not.
Great. So we're going to wrap it up. So thank you for covering colorectal cancer in Colorectal Cancer Month. If anyone watching this program knows someone that would benefit by watching it, it will be available for anyone to watch on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel or at the Mercy Cancer Center website. I hope you'll join us again next week. Thanks, everyone.